We at Pharmacross, we are committed in supporting the practicing veterinarians to help our veterinary customers maintain and enhance their knowledge and skills and keep pace with the current standards in the field of veterinary medicine. We are launching today the Pharmacross webinar series. We have the honor and pleasure to have Dr. Javier Roura as the invited speaker to our first webinar, Acute and Chronic Diarrhea in Dogs, Top Tips for the Diagnosis and Management. Dr. Roura is a veterinarian of the Veterinary Teaching Hospital at the Autonomous University of Barcelona in Spain. Dr. Roura received his veterinary degree from the University of Barcelona in 1989. From 1990 to 1991, he completed an internship at the Veterinary Teaching Hospital of the University of Barcelona. He received his PhD in 1999. He was board certified from the European College of Veterinary Internal Medicine in 2004. From 1991 until present, he's been working as a clinical instructor at the Veterinary Teaching Hospital at the University of Barcelona. He is a member of the International Renal Interest Society and Canine Leishmaniasis Working Group. Dr. Roura has been a visiting professor of the Veterinary Teaching Hospitals of Ohio State, North Carolina State, and Animal Medical Center of New York. He has lectured in conferences and has authored books, book chapters, and more than 80 peer-reviewed scientific publications in the areas of infectious diseases and internal medicine in dogs and cats. I would like to invite now Dr. Roura for his lecture.
Thanks for the introduction, Ellie, and thank you for all the audience. Good morning for everybody. It's a pleasure to be here, and the first thing that I want to say is thank you to Pharmacross for the opportunity to do this webinar. Secondly, I would like to apologize my terrible Spanglish, but I hope that with my slides and in English and you could understand all the presentation. But at the end of the presentation, we will have the opportunity to questions, and we have also you will have also my email in order that you have any other question or any other topic that you want to talk with me. So I would like to talk during these next minutes about the clinical management of acute and chronic diarrhea. Why I talk about this topic? Because acute and chronic diarrhea is quite frequent in clinical practice, and so we, as veterinarians, we have many clinical situations where we need to manage adequately these two situations. When we talk about acute or chronic diarrhea, we talk about different situations, totally different situations. Now we start with the acute management of the acute diarrhea, and acute diarrhea have two important problems. First, acute diarrhea is quite common in dogs. So in general practice, we have many cases with this situation. But the majority of these sometimes doesn't arrive to the clinic because most of them improve at home. So it's not necessary the visit at the hospital. Moreover, about acute diarrhea, there is limited research evidence. In fact, the majority of all the publications are expert opinions. So these expert opinions talk about how can manage acute diarrhea, but always is an expert opinion. Never we have until now any guideline or any publication with meta-analysis that can give a clear protocol for the acute diarrhea. So it's more or less a common practice problem, but at the same time, we have few clinical evidence published that we can give as a guide in order to manage all of this situation. In fact, the causes, what we know now about acute diarrhea. We know that the causes of acute diarrhea basically are three possibilities. The first is secondary to non-enteric disease. So the diarrhea is secondary another kind of problem that is outside the bowel. And then we have two other situations inside the bowel. One of them, non-fatal self-limiting acute diarrhea, and the other, several potential life-threatening acute diarrhea. In the first group, in the non-fatal self-limiting diarrhea, we found endoparasites, in general, Toxocara, Trichuris, and frequently Giardia could give this kind of problems, or dietary indiscretion. That is probably the most frequent cause of this non-fatal self-limiting kind of acute diarrhea. In the other side, you have several potential life-threatening acute diarrhea. In general, three possibilities. One, the enteric infection, generally parvovirus is the most frequent. Probably other kind of infectious acute diarrhea, like some bacteria, for example, Salmonella or Campylobacter could be of acute diarrhea, in general, hemorrhagic acute diarrhea. Then we have another kind of situation. In this situation, we have the acute hemorrhagic diarrhea. It's not clear what is the role of the infection in this kind of clinical situation. We found an acute diarrhea, and sometimes we talked about the possibility of some bacteria, like Clostridium, could play a role in this diarrhea. And finally, the surgical disease. And the surgical disease, in general, we know foreign bodies, intussusception, stricture, incarceration. There are several different situations that could be produce an acute diarrhea. However, in general, this kind of surgical disease that can produce acute diarrhea, in general, the vomit is the major clinical sign. So in general, we have could be diarrhea, but always we find vomit, and in general, vomit is the more frequent clinical sign when we have this situation. But as a first important idea, all of three causes that can produce acute diarrhea, in general, the majority of the cases that we have on clinics are self-limiting diarrhea. So self-limiting diarrhea is probably the most important cause in this clinical situation. In acute diarrhea, probably about 70% of the cases are self-limiting diarrhea. But we have two other causes that can produce acute diarrhea. So secondary non-enteric disease. So diseases that outside of the bowel can produce this acute diarrhea. For example, an Addison crisis and a hypoadrenocorticism could be one of these situations. Non-fatal self-limiting diarrhea, and finally, severe potential life-threatening diarrhea. So another important point for acute diarrhea is that the diagnostic protocol to decide what is the cause of acute diarrhea is different between chronic diarrhea and acute diarrhea. In chronic diarrhea, the important thing is diagnosis. So diagnosis is priority. It's priority because if we don't have a clear diagnosis, we cannot do a good management of a chronic diarrhea. In the other hand, when we talk like acute diarrhea, when the cases are acute diarrhea, in this situation, probably appropriate therapy, appropriate treatment is the priority. So it's not necessary to arrive to have a clear diagnosis. The problem usually is treated with a symptomatic treatment. Why? Because probably the majority of the cases, most of 70% of the cases are self-limiting acute diarrhea. So in dogs, in order to arrive at this situation, in order to decide if we can do a kind of treatment or we need to do other kind of test, we need to evaluate the history, the clinical history, together with the physical examination. We need to evaluate a minimum database, and sometimes, in several cases, we maybe need some diagnostic imaging, X-ray or abdominal ultrasound. Why all of this? All of this in order to decide if we have criteria for concern. If we have a criteria for concern in the history, in the diagnostic imaging, in the minimum database, we need to do more tests. If we don't find any criteria of concern, for us is a self-limiting diarrhea, so we don't need to do more tests and more diagnostic tests, and our approach is a symptomatic treatment. So we look this criteria for concern. We look this criteria for concern in the history or in the physical examination. For example, criteria for concern could be chronicity, could be severe weight loss, could be polyuria polydipsia, could be fever, could be vaginal discharge, maybe bradycardia, abdominal distension, or severe depression, severe dehydration or shock, severe abdominal pain, hematemesis, melena, frequent big volume of vomit, vomit of fetid nature, among others. So we have many different criteria that could give a criteria for concern. Or we can look for this criteria for concern in the minimum database. We need a minimum database means, for example, a packed cell volume and total protein, maybe an examination of the blood smear. A minimal blood analysis could be urea, creatinine, ALT, glucose, urinalysis, and maybe electrolytes in order to evaluate some different situation. But sometimes in some other cases, we need other additional analysis. For example, we can do more specific thing like acid-base analysis or basal cortisol or even other kind of blood analysis in the sense of look for this criteria of concern. Each case will be different, but in general, in most of the cases, with this minimum database that is in black in the slide, probably is enough in order to take a decision that there is or there is not any criteria of concern. And finally, in other cases, maybe we need to do a diagnostic imaging. Or maybe we need to do an abdominal ultrasound in order to look for the explanation of this diarrhea, and especially to look for any criteria of concern. So when we talk about criteria of concern, we evaluate these three things. We evaluate a database, we evaluate physical examination, a clinical history, and we sometimes evaluate diagnostic imaging. With these three steps, we look for criteria of concern. And then we try to make a decision. And this decision, with this information for these three steps, we need to answer if it's necessary to hospitalize this dog. Is necessary for this dog an intensive emergency treatment? Is necessary for this dog a surgical approach? There is an underlying non-enteric cause, so the problem is not in the bowel for this acute diarrhea? Or perhaps we don't need a specific and non-specific treatment, maybe is enough in order to treat this patient, this dog. So with all of this information, we make this the answer of these questions. So we decide this. If we don't find any criteria for concern in the physical exam, in the clinical history, in the minimal database, or in the diagnostic imaging, we have probably 70% of the cases, we have a self-limiting diarrhea. So the symptomatic treatment is the best approach for this kind of dog. However, if we find any criteria of concern or more than one criteria of concern, probably we have in a non-bowel or non-enteric cause of acute diarrhea, or we are in front of surgical diarrhea, or we are in front of an acute diarrhea that maybe have more problems in the future. So we need further investigation, and we need also a treatment, but it's not our priority, because our priority is to further investigation in order to decide what is the situation. So we need to make this kind of diagnosis. The diagnosis of acute diarrhea is quite easy in the sense that we need this look for criteria of concerns, and after this decide if there is not any criteria of concern, we probably have a self-limiting acute diarrhea. And the best management or the adequate management of self-limiting acute diarrhea is symptomatic treatment. Why is symptomatic treatment? First, because it's the more appropriate, because a high percentage of self-limiting acute diarrhea means that we have not any problem. And in general, most of these cases improve alone. This is the cause that most of the owners sometimes cannot bring the dog to our clinics because the dog in 1-2 days improve. So most of these self-limiting diarrhea could be improved. But we have a case at the hospital with this acute diarrhea, so we need to decide what is the best treatment for these dogs. And these dogs, the treatment is symptomatic, but the most important is to make a good monitoring, is to do a good follow-up. Why? Because we need to reevaluate the case if it's necessary, if the dog doesn't work very well, if it doesn't improve as we think maybe we need to do other further investigation, or maybe we need to consider changes in the treatment. So this is very important, this follow-up. And this follow-up or control or monitoring would be in general in 24 hours, 48 hours maximum. So in 1-2 days, we need to have a control, maybe a telephone control, and the dog need to have a good improvement in these 2 days, maximum 2 days. If there is not a good improvement, if there is any problem or is any concern for the owner, if there is any other thing that we cannot see that is the normal evolution of this acute diarrhea, we need to reevaluate the case at the clinic in order to look for other criteria of concern or in order to make any other changes in investigation or even in treatment. So we have the causes, we have how we can rule out the different causes that are not self-limiting diarrhea, acute diarrhea, looking for the concerns. If you don't find any concern, probably is a self-limiting acute diarrhea because 70% of the cases is this kind of problem. And later we need to do the best management. And the best management is symptomatic treatment. So in this acute self-limiting diarrhea, the symptomatic treatment have in general 5 steps. The first step is hydration. So when we talk about hydration, we mean that the dog needs to control the potential dehydration for the diarrhea. In general, it's a self-limiting acute diarrhea, so we cannot find any criteria of concern. So the dog can drink water, need to have fresh water, need to have access to this water because it's important to maintain the hydration. And because we didn't find any criteria of concern, we can give this approach with the hydration. So this is an easy step. The second step in the symptomatic treatment on acute self-limiting diarrhea is nutrition. In nutrition, we have 2 different approaches. In general, we have the approach to rest the gut. So fast for at least 12 hours, and then start to give food, little quantity of food, and very often, frequently, and in general, a kind of digestive gastrointestinal diet. Or we can maintain the feeding, so feeding through. This second approach, the feeding through, probably is more appropriate to emergency cases. It's more appropriate for this not self-limiting acute diarrhea. So probably, for example, in parvovirus or in pancreatitis, increase or reduce the morbidity, increase the survival in dogs with feeding through in this situation. In the other hand, when we have a self-limiting diarrhea, probably rest to the good is probably the best approach. However, we don't have any strong evidence for any of both approach. So at the end is the opinion of the experts. And for this opinion of following this opinion of the expert, in self-limiting diarrhea, probably resting the good at least 12 hours is still the best approach for self-limiting cases. So acute diarrhea in these self-limiting cases need the approach with the diet. So rest the diet at minimum during 12 hours and then start with a frequent dosage of food and but a small quantity. Of what kind of food? So in general, we have different diets that we can use in this situation. We during at minimum 3-5 days, maximum 7 days, you can change to one of these diets and start with these diets. Could be a critical care diet, could be a highly digestive diet or gastrointestinal diet, or maybe could be cooked feed or fish if the dog prefer something at home, made at home, than not a commercial food. But one of these three approaches in the diet could be interesting. So after this 5, maximum 7 days of this diet, when the dog improve all the diarrhea, then we can change to the normal diet. And when we do this of changes, we need to do a progressive change of the diet, a probably translation from the diet, the high digestive diet, to a normal diet in the next week. But in general, 3-5 days of this high digestive diet, could meat or fish, or maybe critical care, could be enough in most of the cases of the acute self-limiting diarrhea. The third step could be the warming. The warming in all the cases, not, but of the physical examination or the clinical history, give the information that maybe this dog has not well deworming, or live in, is a dog that have still part of the life is outdoor and indoor life, or outdoor, the entire life of this dog, maybe could be interesting to the approach of the deworming. And when we talk about deworming, we talk about the deworming of nematodes and the classical worms, or Giardia, because only these two have described acute self-limiting diarrhea. Cestodes, like Dipylidium, Taenia, Echinococcus, frequently are asymptomatic and doesn't present acute self-limiting diarrhea. So in general, when we talk about the deworming, we talk about the deworming about Toxocara canis, Trichuris vulpis, Toxocara leonina, and others. And of course, Giardia. So in this situation, if we do a fecal analyze, fecal fresh analyze on clinics, and we found one of these parasites, makes sense to do the treatment. And the best treatment probably in this situation could be fenbendazole, because it can manage all these two situations that can produce acute self-limiting diarrhea. So in general, 30 milligrams kilogram once a day during 3 days for nematodes, and 50 milligrams kilogram once a day for during 5 days for Giardia could be enough in the treatment of acute self-limiting diarrhea if we find any of these parasites in the analyzed feces, analyze of the feces of this dog. The fourth step could be antibiotics, and I say could be because probably we need to avoid the antibiotics in most of the situation, especially never use antibiotics in self-limiting diarrhea, acute diarrhea. Why? Well, there is a very interesting study of the veterinary record in the 2010 where they make a study that look for the opinion of what is the protocol or what kind of drugs use the veterinarians in UK when they treat acute diarrhea. And the results show a very large different kinds of treatments that the veterinarians offer as a first choice for the treatment of diarrhea. As you can see, antibiotics, antiemetic, gastric protectants, miscellaneous, steroids, many different treatments. This is quite strange because we see before that 70% or more than 70% of the acute diarrhea are self-limiting acute diarrhea. So another important point is they give a lot of different kinds of drugs, but 71% of the veterinarians give antibiotic as a first choice in the treatment of acute diarrhea. So this is quite difficult to understand, but it's logical. It's difficult to understand because this kind of diarrhea, the cause of this kind of diarrhea, the self-limiting acute diarrhea, are not bacteria. So we don't need any antibiotic to use in this situation. And if we think about Giardia, it's better to use fenbendazole, so something that just used for parasite than not something like metronidazole that is not enough, have not enough efficacy and you can treat other things and not only parasites. So in this situation, looks not good to understand this decision. In the other hand, is logical because many veterinarians, of course, need to convince the owner. The owner arrives to the clinics because they want a treatment for their diarrhea, the acute diarrhea of this dog. And sometimes an approach just with change the diet and maybe fast during 12 hours and give water looks like something poor. And some of the owners think that maybe we are not treating the dog and maybe lost the confidence in us. So they don't trust us. And so if we give antibiotic, looks like we give a treatment. This treatment doesn't work because the self-limiting acute diarrhea doesn't be caused by bacteria, but could be interesting the use of this antibiotic for this other reason. So antibiotic, just we can use antibiotic in the other causes of acute diarrhea. So not in in self-limiting acute diarrhea. Is not, we don't use this, and we can use antibiotic in the more severe acute diarrhea or in this situation where the diarrhea is secondary to maybe another cause. So if we know that bacteria is the pathogen present for this diarrhea, for example, in Salmonella or Campylobacter, maybe makes sense to use antibiotic. If you have a breached mucosa, so we found blood in feces, especially if we found melena, could be interesting to use the antibiotics. Or if we have systemic clinical sign, like for example, fever, makes sense to use antibiotic. But these three situations are concerns. If our concerns means that if we found one of these situations is not a self-limiting acute diarrhea. So if you have a self-limiting acute diarrhea, we don't need to use antibiotics. So we don't need to use antibiotic because it doesn't work, because we have problems now in clinics, with the use of antibiotics. We don't need to use antibiotic in many cases. So we have now a real problem of resistance of the antibiotics. So it's very important to use antibiotic what is necessary. And self-limiting acute diarrhea in dogs is not necessary. Or in front, for example, a feline interstitial or idiopathic cystitis is not necessary to use antibiotic. So are situations, normal situations, frequent situations on clinics that we don't need to use antibiotic. But it's true that we need to use something because some owners doesn't understand that the treatment is just fast, water, and maybe a gastrointestinal diet. So in this situation, instead to use antibiotic, maybe you can use other kind of treatment. And this is the 5th step of the acute self-limiting diarrhea, the treatment of the acute self-limiting diarrhea. The use of probiotics, prebiotics, or nucleotides that could be interesting. Why could it be interesting? It could be interesting for this reason, that we can solve the use of antibiotics. You need to avoid the use of antibiotics. And with this, for the owner, looks like a treatment. For them, it's a treatment, so we can use this. Moreover, we start to have some evidence of the use in dogs of probiotics, prebiotics, and nucleotides in the treatment of acute diarrhea. For example, in diarrhea, in acute diarrhea of dogs, instead to use antibiotic, in diarrhea associated to stress, or in the use of probiotics, prebiotics, or nucleotides instead to use metronidazole, for example, in acute times. This last publication is for the last year, so it's quite recent publication, scientific evidence that could be interesting for the use of probiotics. So probiotics, prebiotics, and nucleotides could be interesting because in general are safe and well tolerated. So there is some evidence of efficacy in humans, and we have each year more evidence of efficacy in dogs. For example, in probiotics with the use of Enterococcus faecium could be a very interesting approach, or the use of nucleotides could be interesting. These different approaches in the treatment of acute self-limiting diarrhea. And especially could be interesting to use this kind of nutraceutics because you don't use antibiotics. So in acute self-limiting diarrhea, we don't use antibiotics because in general, they give a lot of problems in the future. But could be interesting to convince the owner that we are treated this dog. So as a conclusion for this first part about acute management of acute diarrhea in dogs, we need to maintain these 3 ideas. First, the most frequent acute diarrhea is self-limiting acute diarrhea. So we need to look for criteria of concerns with the database, with the physical exam, with some imaging, and try to don't find any criteria of concern. If we don't find any criteria of concern, we can treat as a self-limiting diarrhea because probably is the most frequent situation in acute diarrhea in dogs, about 70% of the cases. Then symptomatic treatment is the best approach to the self-limiting diarrhea. And the self-limiting acute diarrhea could be interesting, the use of the treatment, symptomatic treatment in different steps. Always control of the dehydration. Secondly, maintain the nutrition, fast nutrition, al minimum during 12 hours. And then, depending on the case, maybe deworming, or sometimes, or in many cases, you can use an alternative like probiotics, prebiotics, or nucleotides. So diet, gastrointestinal diet with a fast of at least 12 hours, and probiotics, prebiotics, and nucleotides could be one of the best options in the treatment because offer a good treatment for the management of acute self-limiting diarrhea and convince the owner that we are doing a good treatment without the use of antibiotic that we need to avoid. So after these questions, after this first part of the lecture about acute diarrhea, we will talk, or we will do 2 questions. The first question with the bullet is, what is the best dietary approach for acute self-limiting diarrhea? Tube feeding through, rest the good 48-72 hours, oral feeding through, or rest the good at least 12 hours. So we can do the poll, and you have now time, several seconds, in order to answer the question. And at this time, I can see if you are could be present here and not is just connected the computer, but you are not listening to me. So we're finishing the lesson. Give several seconds more to the discussion. Okay. Perfect. Okay, you can call the vote because we can close the poll because the majority of the answers are the 4. So rest the good 12 hour, and of course is the correct answer because as we talked, rest of the good. It's true that there is any strong evidence, scientific evidence published about this, but the general expert opinion is rest the good al minimum 12 hours, and later start with a gastrointestinal or high digestive diet in order to give the time to improve the acute diarrhea, especially because in 24-45 hours usually improve. The others, in general, tube feeding, oral feeding through, could be more interesting in worst cases. So in these situations where we have a severe disease, and in these cases could be interesting. And 45 hours, 72 hours of rest of the good is a lot of time because in general, most of these dogs improve along the diarrhea. So in these 3 days, the dog can improve just without food, and in general, this is not necessary to give this more aggressive approach. Just with 12 hours could be enough. And the second question is, what is the most frequent treatment for acute self-limiting diarrhea? Gastrointestinal diet plus antibiotic, gastrointestinal diet plus probiotics nucleotides, gastrointestinal diet plus fenbendazole, or gastrointestinal diet plus water, but ad libitum, both things ad libitum. What do you think that is the best approach after this first part of the presentation of acute diarrhea? Well, we think that we can close the votes because we have more or less the same situation than before. So it looks like the people are attending. So pay attention to my presentation. And of course, a gastrointestinal diet plus probably probiotics and nucleotides could be a very good option, or the best option for self-limiting acute diarrhea. Why? Because rest of a diet during at least 12 hours and a gastrointestinal or high digestive diet later during 3, 5, 7 days maximum, plus probiotics, nucleotides could be interesting because we need to avoid the use of antibiotics, and the owner feel that we are treating the dog. So probably is the best approach. The second most voted is gastrointestinal diet plus water. That could be interesting because at the end, it could be plus water ad libitum, interesting, but we talk ad libitum both things, so gastrointestinal diet and water, and we talked in the presentation that at least 12 hours of fast could be interesting in order to manage, so not ad libitum could be interesting, but after this fast of at least 12 hours. Perfect. So go ahead with the presentation and go to the second part of this presentation. And we will talk now about the other kind of diarrheas that are frequent on clinics, the chronic diarrhea. Chronic diarrhea have three important differences if we compare with the acute diarrhea. In chronic diarrhea is also common, but the majority of the visits go to the veterinarian. So the veterinarian, sometimes more than one veterinarian, because it's an important problem for the owners and is a really nightmare for the owners and sometimes for the veterinarians, the chronic diarrhea. So it's a frequent situation on clinics. But the difference is that we have here more research evidence. We have many manuscripts when we talk about the best management of chronic diarrhea. Could be what is the order of the test, what could be the interesting diet for for a food responsive diarrhea, when we need to do abdominal ultrasound, for example. So there is many different publications that is different. And the third important difference is the diagnostic protocol. In acute diarrhea, we talked that the appropriate therapy is the priority. So we know we don't do a real diagnosis in the majority of the cases. On the other hand, when we talk about chronic diarrhea in dogs, our priority is diagnosis. We need to make a real diagnosis of the problem, because if we don't have this diagnosis, we cannot give a good approach to this chronic diarrhea. The causes of chronic diarrhea are three main causes. Secondary non-enteric disease, so chronic disease that produce diarrhea. So causes that are outside the bowel. Second, secondary bowel inflammation. And third, primary bowel inflammation. The secondary non-enteric disease are renal disease, liver disease, chronic pancreatitis, pancreatic insufficiency, hypoadrenocorticism, neoplasia, and many others. For example, in endemic area, leishmaniasis could be one of the causes of a chronic diarrhea. So in each country, in each place, we'll have many different causes that are outside of the bowel that can produce chronic diarrhea. The second cause, more frequent causes, are secondary bowel inflammation. Most frequent chronic diarrhea in dogs. So antiparasite responsive diarrhea, food responsive diarrhea, and antibiotic responsive diarrhea. And the last is the primary bowel inflammation. So the classical IBD, or another name, the steroid responsive diarrhea. So we have these three causes. So our objective is to decide this dog with chronic diarrhea have a non-enteric chronic diarrhea, have an antiparasite responsive chronic diarrhea, has a food responsive chronic diarrhea, has an antibiotic responsive chronic diarrhea, has an steroid responsive chronic diarrhea, or maybe have a non-responsive chronic diarrhea. These three, food responsive diarrhea, antibiotic responsive chronic diarrhea, and steroid responsive diarrhea are the more frequent causes in the diarrhea, chronic diarrhea in dogs. The most frequent is food responsive chronic diarrhea. The second most frequent is antibiotic responsive diarrhea, and first of these we found steroid responsive diarrhea as a main third cause of chronic diarrhea in dogs. So we need to do a diagnostic protocol in order to avoid all of these possibilities. And how we can do this? Maybe first with non-invasive laboratory tests. Second, with trial of treatment, because most of these causes, for example, food-responsive diarrhea or antibiotic diarrhea, have not any test in order to make a diagnosis. So our diagnosis is after the dog responds to the trial with this treatment. Later, diagnostic imaging, abdominal ultrasound, in order to check if we have a general problem or is a localized problem, and finally, biopsies. Biopsies is the last step in the diagnostic protocol of chronic diarrhea. Never is the first step. Why? Because in general, most of the dogs with chronic diarrhea, we will have mild, moderate lymphoplasmacytic enteritis. And mild, moderate lymphoplasmacytic enteritis could be possible in many diseases. In a chronic giardiasis, in a food-responsive diarrhea, in an antibiotic-responsive diarrhea. So in many other diseases, we can find, or in many other causes, we need to do the biopsies. We have this result in the histopathology. So biopsies is the last step. Only there is one exception. And the exception is when we have a protein losing enteropathy. If we have a protein losing enteropathy, a severe protein losing enteropathy, we need to do the biopsies at the first stage. After the abdominal ultrasound, we need to do biopsies. Why? Because it's a severe and worse diagnosis. It's a severe and worse situation. So we need to know, we cannot spend time. You need to remember that this diagnostic protocol of chronic diarrhea spend time. They spend time because we need to do first one step, second step, third step. Need money. And the third, we need to explain very well to the owner that we are doing this because we need the diagnosis. And we need to treat each time with just one thing. Because if we make a trial treatment and we may mix antibiotics plus probiotics plus changing the diet, we don't know if it responds to one thing or the other thing. The treatment is for the diagnosis. So we have this kind of potential causes. So first step, initial test to rule out non-enteric diarrhea. So this means maybe do a ACTH test in order to avoid a hypoadrenocorticism, or maybe do a basal cortisol in order to rule out hypoadrenocorticism, or maybe do a TLAI in order to rule out pancreatic insufficiency, or CPLAI, or maybe do several fecal examinations, or maybe other kinds of serology for Giardia. So we have PCRs, we have different tests in order to look for this kind of other causes, not enteric causes. Then we need to rule out the parasite, because Giardia, chronic Giardia, could be negative to the initial test. So even if the initial tests for Giardia are negative, if are positive, we have a diagnosis and make a treatment. But if it's negative, Giardia could be intermittent. So maybe we cannot find Giardias in phases, and maybe the diagnosis is chronic giardiasis. So we need an antiparasitic treatment, especially for Giardia. So fenbendazole, 50 milligrams kilogram once a day during 5 days. And if there is an improvement, we need to repeat the treatment after 15 days and repeat the treatment again after 15 days more. So 2 additional treatments. If we need 2 additional treatments, in order to avoid the self-infection, we need also to use, to clean the perianal area with a solution with chlorhexidine at the beginning of the treatment and at the end of the treatment, in order to avoid or eliminate the rest of oocysts of Giardia. If it doesn't respond to the antiparasite, the next step is to rule out food-responsive diarrhea, the main cause of diarrhea. So diets. For the small bowel chronic diarrhea, the diets, the more interesting diets are hydrolyzed diet, or known also with the name of hypoallergenic diets, the exclusion diets, or maybe you can use the gastrointestinal diets. And if you have a mixed diarrhea, bowel, or and large bowel diarrhea, or just large bowel diarrhea, we need to use, or we can use these 3 diets, plus another time we can use an additional diet that could be the diets with fiber. Then, if there is not a response, we use antibiotics. Antibiotics for the diagnosis of antibiotic-responsive diarrhea. You can use or metronidazole, or you can use tylosin. Metronidazole, 15 milligrams kilogram twice a day during 1 month, or tylosin, 25 milligrams kilogram once a day during 1 month, in order to do this kind of diagnosis, antibiotic-responsive diarrhea. If it doesn't respond, the next step is to avoid steroid-responsive diarrhea, or IBD. In that situation, first, we need to do abdominal ultrasound. Why abdominal ultrasound? First, in order to define if it's focal or is diffuse, the situation, if it's what is the structure of the bowel wall, if there is or there are not, or there is not lymphadenopathy, or how about the other organs, pancreas, liver, other kind of organs that we have in the abdomen. Why? In order to decide what type of method for obtention of the biopsies. So if the abdominal ultrasound, after the abdominal ultrasound, the next step is biopsies. And with this abdominal ultrasound, we have decided if it's necessary a full laparotomy to do a full full wall biopsy, or is enough with endoscopy and different biopsies of the different parts of the bowel. And we obtain the final result is the histopathology. And this is important because if the histopathology is moderate, severe lymphoplasmocytic infiltrate, or if the biopsies show a moderate, severe eosinophilic infiltrate, makes sense to use steroids. But if we have a neutrophilic infiltrate, this kind of infiltration, this kind of biopsies, the steroids, the glucocorticosteroids are not useful in this situation. So when we have a neutrophilic, we need to look for another cause. In general, infectious cause are the most frequent etiology that produce this kind of infiltration. So the infiltration with the biopsy could give us the diagnosis, and maybe is not an inflammation, and maybe it's a neoplasia. So this is the interesting part of the biopsy. So in this point, we can have different diagnoses. If we have a diagnosis of non-enteric diarrhea, we need the specific treatment. So if it's a hypoadrenocorticism, we need the treatment of a hypoadrenocorticism. If we have a pancreatic insufficiency, we need the treatment of pancreatic insufficiency. Then, if our diagnosis is antiparasite responsive diarrhea, we have used in general fenbendazole as a good treatment for chronic giardiasis, and could be interesting the treatment at minimum during 5 days, and always repeat twice separated 15 days each one if there is a good response. If our diagnosis is food responsive diarrhea, we need to use this or one of these diets. Could be the diet, could be the hypoallergenic diet, or could be an exclusion diet, or could be another gastrointestinal diet. But we need to use this diet at minimum during 2 or 3 weeks. In 2-3 weeks, there is an improvement, we maintain the diet more time. In 2-3 weeks of this diet, we don't have an improvement, we need to change another diet. For this reason, in general, the first diet that we use as a treatment, as a trial treatment diagnostic trial treatment with diet for a diagnosis of food responsive diarrhea is hypoallergenic or hydrolyzed diets, because it's the best method in order to see if there is a good response or not. If there is a good response, then we can change to an exclusion diet in order to reduce the cost, or maybe we can change a gastrointestinal diet. If it doesn't work with an hydrolyzed diet or a hypoallergenic diet, it's not necessary to change an exclusion diet. The best thing is to change a gastrointestinal diet or to change a fiber diet. It depends on the kind of diarrhea that has the dog. If it doesn't respond to diet and our diagnosis is antibiotic responsive diarrhea, we need a minimum 1 month on one of these antibiotics, metronidazole or tylosin as a treatment. Most of these cases improve, but some of these cases relapse after 3-4 weeks. Some, in general, most of these cases need another antibiotic. Sometimes change the diet, for example, or together with antibiotic. Other times you can use other kinds of antibiotic. If we have a diagnosis of steroid responsive diarrhea, our treatment especially would be steroids or immunosuppression. The immunosuppression, the steroids, prednisone is the best treatment as a first option. And then if we have many side effects or when we decrease the dose and relapse the diarrhea, maybe we can use the other immunosuppression treatments, like, for example, cyclosporine could be the second option for this kind of diarrhea in dogs. And finally, if we have other kind of diagnosis, like neoplasia, like lymphoma, so the treatment will be chemotherapy. So in all of this situation, we use a different treatment because each have a different diagnosis. Sometimes we can use other treatment together with the final treatment. For example, if we have a food responsive diarrhea, sometimes have a good improvement, but not 100%. And maybe using an antibiotic during 1 month, we can improve this diarrhea, and then just with diet, we can maintain the dog without diarrhea. So sometimes we can use other treatment. And finally, in all these situation, nucleotides, probiotics, or prebiotics. So you can use other nutraceutics just as a treatment. For example, in non-responsive diarrhea, we can try if with nucleotides, probiotics, prebiotics, we can change the evolution of the diarrhea. Or in other situation, with an antiparasite responsive diarrhea, with a food responsive diarrhea, with an antibiotic responsive diarrhea, or with an steroid responsive diarrhea, sometimes it's usable, the nucleotides, the probiotics, in order to reduce the treatment or the dosage of steroids, or to reduce the treatment of antibiotic, or look for a better improvement or better response together with the diet. So when we use probiotics, prebiotics, or nucleotides in chronic disease, we have less evidence. There is some evidence in the last years. In the last 5 years, we have some evidence that that nucleotides, prebiotics, probiotics could be useful in the treatment of IBD, in the food responsive diarrhea, or in the antibiotic responsive diarrhea. But a difference to the acute self-limited diarrhea, there are limited evidence of efficacy in dogs. So at this moment could be many interesting as a help of the other treatments. So as a help of acute responsive, antibiotic responsive diarrhea, to the help to the antibiotic, help to the diet in a food responsive diarrhea, help into the corticosteroids, to the prednisone in a corticosteroid or steroid responsive diarrhea. So it could be interesting in all of these situations that we have talked. So finally, as a conclusion, we can say in chronic diarrhea, we can say that the most frequent chronic diarrhea is food responsive diarrhea in dogs, the second antibiotic responsive diarrhea, and the third steroid responsive diarrhea. So steroid responsive diarrhea means biopsy, and biopsy so means that is at the last step in the diagnostic protocol to the other chronic diarrhea, because food responsive diarrhea and antibiotic responsive diarrhea could not be diagnosed by biopsy. Second, the key point is to find a diagnosis. If we have a diagnosis, we can treat, and you can look for an improvement, a total improvement of this dog. If we don't have a diagnosis, we cannot do this. And finally, to look for this diagnosis and to look for the best treatment for each diagnosis, we need to use the diagnostic therapeutic protocol, adequate diagnostic therapeutic protocol. So first, different initial tests in order to avoid non-enteric chronic causes of chronic diarrhea in the dog. Later, use of antiparasites to rule out giardiasis. Second or third, use of different trials of food, different diets in order to confirm a food responsive diarrhea, different antibiotics to treat antibiotic responsive diarrhea, and finally, to exclude neoplasia, other causes, and to confirm an IBD and the type of the infiltration, we need the biopsy, but it's the last step with the exception of a protein losing enteropathy. So we arrived at the end of the seminar, and now we will do the last question that have been prepared. And the question is, which diet are the most useful to treat chronic small bowel diarrhea in dogs? Gastrointestinal, exclusion, or hydrolyzed diets? Sorry, gastrointestinal exclusion or fiber diets, gastrointestinal hydrolyzed or fiber diets, and exclusion diet, fiber diets. What is the best solution, or what is the correct answer? Well, here in this last question, we have a more discussion. Maybe because chronic diarrhea is more difficult, because chronic diarrhea is really a nightmare for owners and also for veterinarians. Probably the right answer is gastrointestinal exclusion or hydrolyzed diets, because you talk about a small bowel diarrhea. Fiber diets that are not useful in a small bowel diarrhea, small bowel chronic diarrhea, because this kind of fiber are useful in the large bowel, but not in the small bowel. But so fiber diets could be interesting if we have a mixed chronic diarrhea, so a small bowel and chronic bowel, a large bowel diarrhea. This is quite frequent, so it's not unusual to have this mixed diarrhea, or you have just a large bowel diarrhea where fiber diets is very interesting. So we arrive to the last question, and we arrive to the last slide. So thank you very much for your attention. Here you have my mail if you have any topic or any question about this webinar or other things about internal medicine, because it's my specialty. Thanks again to PharmaCross, and now maybe we can have several minutes in order to answer some of the questions. The other question you can send me directly to me to the mail if you want, or could be probably answered directly. So I wait for.
Thank you, Dr. Roura. I would ask the audience now to place their questions in the chat box, so that Dr. Roura can answer.
Well, yeah. For example, there is one question. One question is, what we can do with the owner who the dog is eating raw diet, and they are not like to use commercial food or cooked food. This is a real problem. We know now that raw diet could be the cause of some of these acute difficult diarrheas, especially acute hemorrhagic diarrheas, for example, secondary to Campylobacter or secondary to Salmonella. However, if we think that is a self-limiting diarrhea and the owner could not, they don't want to change the raw diet, so you can use the same raw diet and maybe you just do a fast of 12 hours and then start with the raw diet and water, and maybe an addition of a probiotic plus nucleotide could be interesting. And it could be the best option, because in other situations maybe the owner we don't like. If we don't think that the raw diet is the cause of the diarrhea, the acute diarrhea, so it's not a non-limited, if it's not a non-limiting diarrhea, in this situation we need to avoid the raw diarrhea. But if we think that is a self-limiting diarrhea, it's not necessary to change the diet. Another question is, should steroid be used before biopsy? The answer is not. This is the reason why we put the biopsies at the end of the protocol, because we need to know if it's a moderate severe infiltrate, but not only this, is a moderate severe infiltrate, lymphoplasmocytic infiltrate or eosinophilic infiltrate, because if it's a neutrophilic infiltrate, the steroids are not useful in this situation. Of course, we are clinicians, because not all the people could do the biopsy for problems with the money or for other kind of reasons. In these situations where we cannot do this, we maybe can use a steroid without biopsy, but always after the rest of the protocol. So after of the test for non-enteric causes, after the anti-parasite treatment for Giardia, and after the food-responsive diarrhea treatment, after trial, after the antibiotic trial, then maybe we can use the steroid. But if it's possible, better is first do the biopsy. Well, we look for other questions. If there is another, more of them are thank you to you for the attention. Here I have another. Can you use some natural alternative in order to prevent the diarrhea? There is not many studies about which alternative we can use to prevent the diarrhea. What is it to treat the diarrhea? To treat the diarrhea, there is no any alternative or natural alternative, but in fact, the nucleotides, the prebiotics, the probiotics, Enterococcus faecium, these are natural alternatives, so are nutraceutics, and you can use this kind of natural treatments for the acute for the treatment of acute diarrhea. To prevent the acute diarrhea, this is more difficult, but there is some studies that the use of this kind of probiotics, especially Enterococcus faecium, some prebiotics or some nucleotides, is interesting, that looks like prevent or minimum decrease the number of diarrhea, even in dogs and even in cats, especially in a stress situation or when live a high number of dogs or a high number of cats together. So in this situation, looks like this kind of natural alternative could be useful for the treatment to prevent the diarrhea. But to treat, there is many few reference or bibliography about this, and we need not forget that nucleotides, probiotics, and prebiotics are natural. So maybe it's better and more useful than not use antibiotic. Another question is, are you using loperamide in some cases? Loperamide produce an slow of the movement, a reset of the movement of the bowel in order to decrease the diarrhea. Is forbidden to use loperamide in all the cases, especially in these where we have a cause inside the bowel. For example, toxins or bacteria or virus or a problem with an osmotic problem with the diet. So we are forbidden. Where can use? Only one situation, in the chronic chronic large bowel, irritable large bowel. So in this situation, which is a situation where we found all the trials are negative, there is not response, the biopsy is normal. In these situations, maybe we can use loperamide. In general, together with a diet with fiber diet with loperamide could be a good alternative for this kind of specific chronic diarrhea. It is a large bowel irritable chronic diarrhea, but only in this situation. And this situation is quite frequent in human medicine, but is less frequent in dogs and cats, but could be. So in this situation, could be useful. Talk about what is about the treatment about trichomonas. About trichomonas, I don't talk this in this lecture because we talk about chronic diarrhea in dogs. In cats, of course, trichomona could be interesting in the treatment because some chronic large bowel diarrhea could be frequent in cats, and in cats, trichomona doesn't respond to metronidazole, doesn't respond to fenbendazole, and the only treatment that we can find for trichomona is ronidazole. So in these cases, ronidazole could be used. In dogs, we don't have this kind of problem, so the problem is Giardia, and if we found something that looks like a trichomona in a dog, is a Giardia, so we need to treatment with Giardia, and Giardia could be treated, best treatment is fenbendazole. We can use Febantel, for example, Trontal Plus could be interesting because Febantel is metabolized to fenbendazole, so is useful for the treatment. And the less useful treatment in dogs for Giardia is metronidazole. It's useful, but it's the less useful treatment. Ellie, when you need to finish, to tell me something. Here,
Xavi, we have so many people online. It seems like everybody wants to listen to the answers that you give to these great questions. So please feel free to continue.
No, I will talk. So, but when you see, I don't know the people that are connected. So when you feel yeah, is enough.
We have more than 300 people online at the moment.
You just tell me. Okay. Another question is: could the use of steroid mask and neoplasia disease and cause a difficulty in this diagnosis? Yes, is one of the reasons what we don't use steroids before the biopsy, no? Especially for lymphoma. In cats is less, the problem is less important because in cats the use of steroids is one of the most useful treatment for lymphoma. But in dogs, the chronic use of steroids looks like maybe produce at the end a resistance of the other chemotherapy. So if the other chemotherapy could be used, it's better to do first the diagnosis with a lymphoma, and with the pass of the time, maybe then reappear the lymphoma, because steroids is not only useful for lymphoma in dogs, so it's better not use steroids if we have the suspicion of a lymphoma, or we have a clear suspicion in our differential diagnosis of lymphoma. Another question is, what do you think about using kaolin, pectin, and other really are not prebiotics, no? Okay, so kaolin and pectin are not prebiotics. Prebiotics is usually different kinds of fever. Some of them hydrolyzed fever, and others cannot metabolize this fever. But kaolin and pectin could be interesting. In general, are associated to this other treatment. So most of these treatment have a prebiotic together kaolin or pectin, or have another kind of probiotic, prebiotic, nucleotides, other things maybe are mixed with kaolin or pectin. These kind of products are in order to compact. The only usefulness of this kind of products is to compact the feces, so can help, but in theory is similar to loperamide. We need to use loperamide just in some situations. Here, of course, help, but doesn't cure. So the useful of these products is for the other products. So kaolin and pectin are useful, but together with a probiotic, or together with a nucleotide, or together with a prebiotic, if not, usually alone are not enough to the treatment. Here talk about what do you think, what do you do with a patient with extra defecation? I assume they'll have tenesmo and have mucus in the feces, and he react or responds only to glucocorticosteroids. Well, if responds very well just with glucocorticosteroids, in theory, you have a large bowel diarrhea and a steroid responsive diarrhea. So it responds very well to corticosteroids. The other problem is when we try to decrease the doses of corticosteroids, it relapse again the problem. So we cannot stop never the corticosteroids. In this situation is where we can use together with corticosteroid other treatment. For example, if it's a large bowel diarrhea, like looks this case, you can use steroid together with a diet with fever, and with that fiber, and you can use this both. And then, when improve, try to decrease slowly the dose of corticosteroids in order to see if with less doses of corticosteroids you can maintain the dog well, or even you can stop the corticosteroid in the future, for example, or you can use probiotics and nucleotides together with the steroids in order to improve this, or if these respond to corticosteroid, but you cannot stop them, but you can decrease, or you have several side effects secondary to the corticosteroid treatment, you can introduce another immunosuppressive treatment, for example, cyclosporine. Cyclosporine needs 15 days more of corticosteroid, and after 15 days more of corticosteroid plus cyclosporine, you can try to decrease the dose of corticosteroids in order this, if just with cyclosporine can improve. And if for monetary problems you cannot use cyclosporine, you can add, for example, I lost the name. Other kind of immunosuppressive, like other, in order to decrease the doses of the corticosteroid. But at this moment, glucocorticosteroid is the first option, and probably in gastrointestinal problems in dogs and cats, probably cyclosporine is the second drug of option. Well, another question is, in case of acute hemorrhagic diarrhea, what we can do to stop the hemorrhage. Acute hemorrhagic diarrhea is a peculiar diarrhea. If it's an acute hemorrhagic diarrhea, idiopathic acute hemorrhagic diarrhea, in general, usually have an hematocrit, a PCB of more than 60, generally 60% of hematocrit. Usually are small breeds, usually are adults, and the management is fluidotherapy in order to control the shock. And some authors use antibiotic because think that maybe Clostridium plays a role in this situation. So antibiotic that could be effective with Clostridium maybe could be useful here. To stop the hemorrhage, there is not any treatment, specialist treatment in any hemorrhagic diarrhea if it's not secondary to intoxication with coumarins. There is not any special treatment. Some author, if you have hemorrhagia in the bowel, use omeprazole, for example. So some drugs that can modulate the pH of the stomach, but only some authors give this. The other is to treat the cause. So in acute idiopathic hemorrhagic diarrhea, fluidotherapy. In acute hemorrhagic diarrhea secondary to parvovirus, the treatment is symptomatic. So the use of fluids and other kind of treatments, analgesia. If the diagnosis is acute hemorrhagic diarrhea secondary to salmonella, the treatment is the use of antibiotics effective against salmonella. I change the food, gastrointestinal, don't work, and hypoallergenic. When do I do corticoid? Only 1 in 2 weeks. So sometimes the usefulness of the diets is in order to decrease the dosage of corticosteroid. If we can maintain a dog clinically well or quite well, just using diet plus corticosteroids twice a week or once every 2 weeks or other thing, most of these dogs is a real improvement, so could be interesting. So in general, when you use so low dose of corticosteroids, in general, is because they don't need corticosteroids. So maybe with diets, other combinations of diet plus antibiotics, diets plus probiotics plus nucleotides could be interesting in some of these treatments. This is the reason to use the diagnostic protocol, adequate diagnostic protocol. This is the reason why first we need to do a trial with diet. This is the reason that don't use corticosteroids without biopsy. This is the reason why every time just one treatment. Because if not, we cannot know if the response is to the diet or to the corticosteroid, or the response is to the diet or to the antibiotic, or the response is to the probiotic and nucleotide or the diet. So always first one treatment, response to this treatment, just response for diagnosis, food responsive diarrhea, antibiotic response, antibiotic responsive diarrhea, and later you can use other treatment in order to improve the situation. But in a food responsive diarrhea or an antibiotic responsive diarrhea, they don't need corticosteroids. Because allergic diarrhea or allergic enteritis is not corticosteroid responsive. So in these situations, probably is IBD, an steroid responsive diarrhea, that with the diet we need to use less steroids, or is a food responsive diarrhea, but we need to change the corticosteroids and look for other things, because if not, doesn't respond to corticosteroids. Well, here there is, you have a cases similar to hemorrhagic gastrointestinal enteritis, healthy dogs with very painful abdomen, with vomits, and surgical, and in the surgeon, laparotomy, they find a black, small, and large bowel, intestinal lesions, and animals die quickly. In general, this is one of the situations, is a surgical situation, so is not here. The diarrhea is not the most frequent clinical sign. We have always severe vomiting. You have a concern, that is the painful abdomen. So you have criteria of concern. And in this situation, probably we need to do other tests, for example, abdominal ultrasound. In these cases, probably you have a mesenteric torsion. It's the main common cause that produce the same clinical signs of hemorrhagic gastrointestinal syndrome, but with these black, small, large ileus, because they produce this kind of torsion in the mesenterium, and this produce the death of the dog very fast if we cannot make a fast surgeon. If just in few hours or less, in minutes of the torsion, we have some options. If you spend more time and they spend more time to arrive to the clinic, when they arrive at the end, we need to put into sleep the dog, because it have not possibilities to make a solution.
Dr. Roura, being conscious of time, you have received so many great questions, and I think it's time that we wrap up. Okay. So maybe you take one more question, and then we close this webinar. Mm-hmm. And people can still send you an email with their questions if their question has not been answered.
Yes, of course. If I receive 350 questions, maybe it would be not very interesting for me. But of course, I prefer maybe some question I can answer for my email, or maybe more cases, or some cases maybe is better some exchange some doubts or some ideas for a mail for some cases, just for questions. Well, someone yes, but if I have a lot, what will be impossible for me to answer of the question. But they will have I think that the attendants will have this presentation, so maybe in PDF or maybe available in video, so they can again see the presentation or watch the video. And so I assume that most of these questions will be answered. The last question is about the treatment of fenbendazole, and when they talk what is the protocol, the exact protocol and the period. I explained this about the treatment of fenbendazole for chronic giardia. The treatment is 50 milligrams kilogram once a day during 5 days. In general, with one treatment is enough. There is a real improvement, but even if you have a real improvement, if the dog has a chronic diarrhea and responds to the fenbendazole, is better. In order to avoid again relapses for reinfectations, it's better to repeat twice the treatment. So again, 5 days of fenbendazole, 15 days after the finish of the first treatment, and again a third treatment 15 days later after the treatment, the second treatment with fenbendazole. So at the end, 3 treatments separated 15 days each one. So thank you very much for your attention. I hope that could be interesting and I can answer many of your questions or your doubts. And you have my email, and if I can, I will answer some of your questions. And thank you for the attention, and thank you Pharmacross for the idea of the webinar, and I hope that this works very well. Thanks.
Thank you, Dr. Roura, so much for your excellent lecture. And a big thank you to all our participants. We had over 300 people joining us today with some great questions. So thank you very much. Feel free to get in touch with your local PharmaCross representatives if you have any questions about PharmaCross products. I wish you all a wonderful evening, and I look forward to seeing you all again in a future PharmaCross webinar. Goodbye.